Good day, everybody. My name is Andrius Zucenka. I'm a hematologist and a researcher in Vilnius University Hospital, Santaros, Klinikos. Currently, we have published an article regarding the venetoclax-based salvage therapy with a maintenance strategy versus salvage FLAG-IDA for AML patients who have relapsed or have refractory disease after an allo transplant. So this was a retrospective analysis. All the patients had either relapsed or refractory AML post-allogeneic stem cell transplant. We have identified 20 patients who had been treated with a triplet regimen based on venetoclax in combination with low-dose Cytarabine and actinomycin D. So this triplet regimen is used for induction, and if patients respond, they continue their treatment with either maintenance, which is low-dose Cytarabine plus venetoclax and donor lymphocyte infusions, or they proceed to second allo transplant. The control arm patients were actually the FLAG-IDA, the standard salvage intensive therapy based on a high-dose Cytarabine in combination with Fludarabine, Idarubicin, and G-CSF. So patients after responding to FLAG-IDA could proceed to consolidation with donor lymphocyte infusions or second allogeneic stem cell transplant during the aplasia period. The main differences and the main characteristics of the patients are in this table. As you can see, the median age was a little bit older in the active cohort. However, the difference was not that significant. On the other hand, the number of patients who were older than 55 years old were significantly higher in active group. The ECOG status was pretty much similar in both groups. A little bit more patients with the ECOG 2-3 in the active group. The ELN risk group certification, pretty much all the groups were quite different. As you can see, regarding the previous treatment, the majority of patients in both groups, of course, had received intensive chemotherapy before allo transplant, and most of them with a high-dose Cytarabine based regimen. Of note, the active patients, actually, we had cases here with previous venetoclax exposure and who had previously received a FLAG-IDA regimen, whether a salvage or induction treatment. None of such cases were identified in the FLAG-IDA group. There were some differences in the conditioning regimens. As FLAG-IDA patients were younger, more of them had received myeloablative conditioning. On the other hand, the active patients more often received reduced intensity conditioning. Of course, we can see the age difference here as well. An important difference between the two groups was actually the time from transplant to relapse, and here we have a significant difference that active patients actually they relapsed earlier, significantly earlier than FLAG-IDA patients. The median time was almost 7 months compared to more than 12 months in the FLAG-IDA group. And of course, the majority of active patients relapsed within 12 months from allo-ASCT, which is, of course, always difficult patients to treat when they relapse very early from transplant. So those cases, the number of such cases was lower in the FLAG-IDA group. Regarding the efficacy, what we have noticed and what we demonstrate that actually the overall response rate in the active group was 75%, which is high in this cohort. It was quite similar to the FLAG-IDA with 66%. As you can see, the composite complete remission and complete remission without platelet recovery rates were somewhat different. However, as some patients in the FLAG-IDA group proceeded to a second transplant in aplasia, during the aplasia without hematological recovery. So basically, we could not evaluate their hematological recovery, and then those patients were considered as having achieved a morphological leukemia-free state. So I think the anti-leukemic efficacy of both regimens is quite similar based on the overall response rate. The MRD negativity, the higher MRD negativity was observed in active patients. As this was a retrospective analysis, Some FLAG-IDA patients were not evaluated for MRD, especially the ones who received FLAG-IDA earlier. So I would take cautiously these numbers. Post-response treatment, as you can see, 15 responders have proceeded. The majority of them proceeded to maintenance therapy plus DLI in the active group. Some of them had received second transplant, whether the majority of FLAG-IDA patients proceeded to second transplant, and some of them had DLI. So there were differences in the post-response treatment here as well. What about toxicity? Well, this is an important finding that actually we had differences, especially regarding febrile neutropenia, catheter-related infections, sepsis, septic shock, and transfers to the ICU. These factors were these adverse events were observed much more rare in the active group rather than in the compared to FLAG-IDA patients. And that is an important finding. So basically, we have a better toxicity profile, especially regarding the life-threatening infections. What about GVHD? Well, we see that grade 3-4 GVHD was quite common in the FLAG-IDA group, and I think this can be partially explained by the fact that some of those patients proceeded to a second transplant in aplasia without additional immunosuppression. So maybe that was the cause of high grade 3-4 acute GVHD numbers. Regarding the mortality, what we see, we have no treatment-related mortalities in active patients, and the fertility mortality was 0%, and it was quite different when you compare that to FLAG-IDA patients, when we see almost a third of patients dying from treatment-related causes rather than relapsed disease. And of course, the early mortality was high. And regarding the hematological recovery in our responding patients, the times were quite similar, maybe a little bit shorter in the active group, but those differences were not significant. Of course, it's very important that in the majority of patients, venetoclax was stopped earlier than day 28, especially in those who had serious infectious, or we performed an earlier bone marrow evaluation and confirmed a morphological leukemia-free state, and then we stopped venetoclax just to let the counts go up earlier. The median time of venetoclax, the median days of venetoclax was actually 19 in this group, so that was the median day when we stopped venetoclax, not day 28, and that's an important finding that we can stop venetoclax earlier, especially in early responders, or of course in patients who have life-threatening infections. So regarding survival, what we see that actually active patients significantly survived longer than FLAG-IDA, with a median overall survival exceeding 13 months, which is quite a good finding in this difficult to treat group, and FLAG-IDA group, of course, we're doing worse, sadly, and mainly, as you can see, the treatment-related mortality was the main factor here. You can see that in patients who had relapsed earlier than 12 months after transplant, the difference was even more pronounced, and here the active regimen curve looks quite a bit better than FLAG-IDA. So basically, these are early relapses. Some of those patients are still on immunosuppression. They still haven't coped with the complications after transplant, especially those who are after myeloablative conditioning. So here we have a big difference here. Regarding the anti-leukemic efficacy, as I mentioned, regarding the responses, the relapse, the cumulative incidence of relapse was quite similar in both groups. So we don't have a much better disease control and a prolonged remission duration. However, the toxicity, I think the toxicity here is very important, and we've performed the Cox regression analysis, and as you can see, the active treatment was actually seems to be better for all the subgroups, rather regarding conditioning or age or time to relapse. Both earlier relapses and later relapses are doing better with active therapy. And of course, that is important, that it's significant for all the patients when we take them into two groups. An interesting finding was that patients after active therapy achieving MRD negative response was actually pretty much demonstrating a high survival. And the blue curve, as you can see here, these are the MRD negative patients. They're doing really well, and the time, as you can see, it's exceeding 2 years. And we're very happy about these patients, and they're doing really well. So MRD negativity, it seems to be essential for remissions, for sustaining remission and keeping those patients without leukemia and possibly even cured. Of course, patients with MRD negative disease, sadly, but they relapse. You can see here the relapse rate here, and of course that translates in a worse overall survival. So to conclude, it seems that this triple regimen with venetoclax, low-dose Cytarabine, and actinomycin D produces high response rates, which are actually comparable to standard intensive chemotherapy, FLAG-IDA regimen. The toxicity seems substantially lower of active than compared to FLAG-IDA. Patients with prior venetoclax or even after FLAG-IDA have responded to active. That's an important finding, I think. Of course, the numbers are very low, but still some tendencies can be seen. And of course, that MRD negativity achievement is very important to sustain remission. And actually, we also demonstrate that the maintenance strategy with low-dose Cytarabine venetoclax with the addition of DLI, and several patients were actually MRD positive after induction. However, they became MRD negative after implementing maintenance with donor lymphocyte infusions, and that is very important and actually proves us that maintenance strategy with donor lymphocyte infusions can be effective in putting those patients in MRD negative deep responses. Of course, there are major drawbacks of the study. It was a retrospective analysis. The groups were small. There were some intergroup differences regarding age, time from transplant to relapse. Active patients had actually received reduced intensity conditioning more often rather than myeloablative conditioning in the FLAG-IDA group. And of course, there were differences in the consolidation tactics. However, I think our data actually can produce some thoughts that venetoclax-based therapies with their lower toxicity can be successfully implemented in these post-allo AML relapses, especially in older patients and more frail patients and those who have relapsed very early after transplant. So thank you for your attention, and best of luck to all of you.